Yes, sir. So good afternoon, everyone. At the outset, thank you, AOS and Shamik, sir. So yes, I will be speaking that encirclage is must in every case of vitrectomy in cases of RD. Skippins, long way back in 1960, said that RD is a manifestation of complex interrelationship between retina and vitreous, and it is not an isolated disease, just like vitreomacular interface disorders. So let's go back to basics. Vitreous base straddles peripheral retina and pars plana, and it is the strongest attachment, and its removal in toto is impeded by the posterior convexity of the lens and non-availability of the convex vitreous cutters, which means that it is impossible to remove 100% of the vitreous. Now, if you look at the etiology of the recurrence, the reopening of breaks and the anterior PVR is one of the most leading causes of the recurrence. So the failure rate after the single surgery without encircling band is almost around 28%. Also, anterior PVR contributes to approximately 86% of the recurrent RD cases. The prognosis is poor if it is because of anterior PVR, and also the vitreous incarceration if seen in the sclerotomy sites. So there is the need of encircling band in cases of all the cases of RD, as it supports the base. It not only approximates the layers of the retina, but importantly, it relieves circumferential and AP traction. Incomplete tamponade fill leads to residual fluid cuff between the tamponade and the retina, which is tackled by this encircling band. Only vitrectomy means incomplete base excision, or else the risk of lens touch in phakic patients leading to lens removal, or in cases of pseudophakic, it will lead to subluxation or decentration of the lens. Well, my opponent will say about base excision with models like Carl Class, but for us, it is like a Ferrari in the hands of a driver who is accustomed to Maruti 800. Residual fluid cuff, I have already alluded to, which is the truth because of the residual vitreous in all the positions, whether it is supine, upright, or the prone position. True medicine is evidence-based. So these are the various studies which shows the superiority of combined surgery over the plain vitrectomy. This meta-analysis in 2018 showed protective effect of encircling band in prevention of recurrent RDs after SOR. This meta-analysis of 1,704 patients clearly showed odds ratio in favor of PPV with encircling band. In cases of inferior RD, also in the pseudophakic RDs. Primary retinal detachment outcome study recently published in 2020 in Ophthalmology Retina clearly shows the superior single surgery success rate with encircling band in all types of phakics and even in superior retinal detachment cases. Besides this study showed that the additional benefit of protective effect against the progression of diabetic retinopathy. And friends, if you have a recurrent RD after vitreous surgery, it is more severe and less forgiving. Yes, nothing is perfect. Limitations is the truth of life. My worthy opponent will talk about more morbidity with buccal, that is, the short-term gain often leads to long-term pain, while initial pain means long-term gain. He will talk about the myopic shift, which is usually 2.570, and for presbyopic, it is of the glasses. While for other patients, you can think about refraction if you have attached retina. But in an attempt to avoid the glasses, if you have failure, then what is the use of emetropia? So now, and he will also talk about the buccal infections. But with sutureless scleral buccal, this limitation is also taken care. And also you look at the infection rate versus recurrence. So to a surgeon, the time should not be any consideration. Long-term investments like mutual funds versus short-term investments like stocks can lead to crash as well. So friends, encircling band is time-tested and has long-term benefits. So well said. Trendy is the last stage before being tacky. So, एक से दो भले, and it's always better to combine the strengths of the buccal and vitrectomy for improved success. Thank you.